So in the previous part, we were discussing about the odontogenic tumors. So we were on the second category. So next we were studying about the ameloblasttic fibroadontoma. Now, according to WHO, it's a lesion similar to the ameloblasttic fibroma, but showing inductive changes which leads to the formation of dentine and enamel. So basically, they are hematomas. What happened here is we can see ameloblasttic fibroma along with the complex odontoma. So clinical features, they occurs below the 10 years of age. They are usually asymptomatic and the associated to it fails to erupt and causes swelling. So radiographically, it shows well circumscribed solitary or multiple small radiopacities. Histologically, it shows combination of the ameloblastic fibroma and odontomas. So as you can see in this picture, it's a typical ameloblastic fibroma-like area, which is merging with the odontoma-like area. So this area is the ameloblastic area, and this is your odontom-like area. Now, as you can see, there is induction of the thin layer of the 8 tubular dentine in this trauma by the ameloblast-like cells. ये देखो ये आपकी ameloblast-like cells हैं, which are induction into the thin 8 tubular dentine in the stroma. Now, this is a primordial odontogenic tumor. It was first described by Moscow Taylor et al. It is a benign odontogenic tumor which develops during the primordial stages of the tooth development. It is classified under the mixed odontogenic tumors, that is dental papilla surrounded by a delicate ameloblastic epithelium. Till now, only 14 cases has been and it occurs in the young age, that is in the second decade of your life. It has slightly male predilection. Mandible is the most common site, usually the unerupted tooth. Now it shows asymptomatic swelling presenting with the expansion of cortical. Now when we see X-rays, we will see the large, well-defined radiolucency, which involves a completely unerupted tooth, usually third molar. We will see root resorption, buccal and lingual cortical plate expansion, and encapsulated solid nodule, which is pale and slippery. Now you can see radiological features of primordial odontogenic tumor. Differential enclosure, ameloblastic fibroma, central odontogenic fibroma, and odontogenic myxoma. Histopathologically, it shows variably cellular to loose fibrous tissue with areas which mix dental papilla surrounded by the epithelial cells, either cuboidal or columnar. No hard tissue formation is seen, and calcification may be seen in the myxoid connective tissue stroma. As you can see, आपके यहाँ पे columnar cells हैं और ये आपका connective tissue है पूरा. Treatment includes enucleation, extraction of the involved tooth, conservative होता है, surgical excision, prognosis इसकी good है, and recurrence rate is rare. Then next is your dentinogenic ghost cell tumor. COC, that is calcifying odontogenic tumor, was first described by Gorlin and his colleagues in 1962. इसीलिए हमने calcifying odontogenic cyst का सबसे पहला नाम दिया था as a Gorlin cyst. Now, but there was a controversy whether COC is a cyst or tumor. So इसके लिए दो principles इन लोगों ने follow किए. First was a monistic concept which postulates that all the COCs, जितनी भी आपकी calcifying odontogenic cysts are, they are neoplastic in nature, even though majority are cystic in architecture and they appears to be non-neoplastic. Then there was a dualistic concept which favored by the most researchers, which states that COC, that is calcifying odontogenic cyst, की दो variety होती है. That is, one is the cyst and second is the tumor. So if it is a cyst, so it is called as calcifying cystic odontogenic tumor. If it is a neoplasm, so we will call it as dentinogenic ghost cell tumor. So DGCT term was first reported by Pretentious et al. In 1981 for the neoplastic variety of COC, that is type 2 of COC. It also has been termed as odontogenic ghost cell tumor by Columnaro et al. Now it is an extremely rare odontogenic tumor and it has central and a peripheral type. अब it develop कहाँ से होता है? Develop from the cell rest of serraces or from the surface epithelium, but mainly इसकी histogenesis is unclear. Now what happened is there is a compound called as beta catenin which plays an important role in the tumor genesis. ये क्यों as a tumor उसको बोला जाता है? Because एक compound होता है beta catenin. जैसे हमने COC में पढ़ा था एक gene PTCH, यहाँ पे gene है beta catenin which plays an important role in the tumorigenesis by an improper differentiation process coordinated by WNT signaling pathway. अब ये आपका जो WNT signaling pathway होता है ये आपका कब बनता है? जब आपका tooth formation start हो रहा था, that is from bird, cap और bell stage, उस पे ये सिग्नलिंग पाथवे एक्टिवेट होता है ताकि आपकी जो ये स्टेजेस है वो एक स्टेज से दूसरे स्टेज में जाने के लिए आपका ये पाथवे यूज होता है. तो वहां पे कभी कभी आपका इम्प्रॉपर डिफरेंशिएशन होता है बिकॉज ऑफ द बीटा कैटेनिन, जिसकी वजह से आपका सीओसी डेवलप होता है. Now usually seen around the 15 years of age, but vary करते 17 to 72 years. Again, it has male predilection. Maxilla is more common than the mandible. Canine to first molar region mostly affected होता है. Usually it is asymptomatic. Very rarely we will feel pain or discomfort. But mainly seen in the tooth bearing area or in the edentulous jaw. Now, radiographically, it is unilocular and multilocular both. It shows radiolucency with scattered radiopaque calcifications. Now, occlusal radiograph में आपको क्या दिखता है? You will see the bicortical expansion. That means expansion on the two sides, either buccal or lingual or mesodistal. Now, root resorption or an impacted tooth in relation to the tumor mass is also noted in some cases. Now, as you can see, आप देख रहे हो यहाँ पे ये पूरा एक radiolucent area form कर रहा है. Now, histopathologically, you will see islands of the odontogenic epithelium. Then next, you will see tall columnar ameloblast-like cells with the hypochromatic nuclei. You'll also see large areas of eosinophilic globules, which are suggestive. And as you can see, ये ghost cells है जिनका calcification हो गया. These are your giant cells, and ये dentine-like cells है, which is suggestive of large areas of eosinophilic globules, which is suggestive of dentinoids. And you will see ghost cells which shows keratinization and calcification. The treatment include your enucleation or surgical resection. It is a locally aggressive lesion. Recurrence rate iska high hota, that is around 71%, and in many cases malignant transformation happens. The next is an enameloma, also called as enamel pearl. These are basically small focal excessive mass of enamel, that is ectopic nodule on the surface of the tooth root. You can see ये देखो आप छोटे छोटे से ये एक्टोपिक नोड्यूल बन रहा है, दैट इज द मास ऑफ एनामल बन जाता है रूट के सरफेस पे. अब ये छोटा वाइट एकदम जैसे मोती जैसे नहीं होता वैसे दिखता है, दैट व्हाट इज कॉल्ड एज एनामल. Mainly seen at the furcation of the roots or near the cemento-enamel junction. The axillary molars are more commonly affected than the mandibular molars. They are usually asymptomatic और इनका higher incidence होता है in the mongoloid and Eskimo populations. Now, pathogenesis, if we see, there is a localized bulging of the odontoblastic layer, which causes prolonged contact between the herpes epithelial root sheet and the developing dentin, which causes inductive influence and leads to the formation of enamel. Basically, हो क्या रहा है, आपकी herpes epithelial root sheet से आपकी root develop होती है, तो कभी कभी जो आपकी ओडोंटोब्लास्टिक लेयर यानी कि जो लेयर आपकी ऊपर इनामल और डेंटिन बना रही है उसका बल्जिंग आउट, दैट मींस वो थोड़ी सी रूट क्राउन फॉर्मेशन की जगह रूट फॉर्मेशन में आ जाती है, जैसे आपका herpes epithelial रूट शीट. अब डेंटिन तो आपका रूट में भी है क्राउन में भी है, तो जो डेंटिन आपकी रूट में फॉर्म हो रही है, अब उस लेयर का बल्ज होने की वजह से आपका जो लेयर आपका रूट बना रही है उसका और डेंटिन का कांटेक्ट होता है. अब जब वो दोनों लेयर्स आपस में कांटेक्ट करती हैं तो वहां पे इंडक्टिव इन्फ्लुएंस क्रिएट होता है, जिसकी वजह से इंस्टेड ऑफ क्राउन रूट में भी नावल फॉर्मेशन स्टार्ट हो जाता है, तो वो एक छोटा सा वहां पे ऐसा नोड्यूल की फॉर्म में प्रेजेंट हो जाता है. Now you can see there's a well defined circular radiopaque nodule. You can see in this picture, even in the first picture, this is a well defined radiopaque nodule. See, now it may consist purely of enamel. It may also contain underlying dentin and pulp tissue. Now complications क्या क्या हो सकता है? It shows weak periodontal attachment, that is attachment by the hemidesmosomes. You see areas of stagnation which favors the plaque retention and improper cleansing. Now, enamel pearl may sometimes contain vital pulp tissue. The next is an odontogenic fibroma, which includes a peripheral odontogenic fibroma and central odontogenic fibroma. The peripheral one includes your peripheral ossifying fibroma and calcifying fibrous epithelium. The clinical features includes a rare lesion, which is usually seen around the 2nd to 7th decades of life. Now, hair and mandible is more commonly affected than the maxilla and usually seen in the gingival area. Now, it's a slow-growing lesion, which varies from 0.5 to 1.5 centimeter in the diameter. It's a firm, sessile gingival mass which is seen between the teeth, which causes displacement of the teeth. Now, histopathologically, it shows cellular connective tissue parenchyma. Non-neoplastic epithelial islands, strands and cords of the cuboidal, columnar, or odontogenic epithelium. Sometimes it shows vacuolated. Now, calcified tissue which resembles bone, osteoid, dentine, osteodentine may be seen. As you can see in this picture. यहाँ पे पतली सी epithelium की लेयर है और यहाँ पे आप देखो पूरा ये डेंटिन लाइक फॉर्मेशन स्टार्ट हो रहा है. You can see that there is a peripheral odontogenic fibroma है. यहाँ पे बहुत छोटे 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 strands है जिसमें odontogenic epithelium है, which is surrounded by the finely fibrillar fibrous tissue. Now next is your central odontogenic fibroma. It's an uncommon central lesion. Now it has three basic concepts regarding this tumor. The first concept says that it's a lesion around the crown of an unerupted tooth, resembles cyst. Second is the lesion of a fibrous tissue which shows scattered islands of odontogenic epithelium. Third concept says that there is a fibroblastic neoplasm which contains varying amount of odontogenic epithelium and calcified material which resembles like the dysplastic dentine and cementum. Now, clinical features include is usually seen between the first to 8 decade of life, but the mean age is 40 years. It has female predilection. Mandible is more commonly affected than the maxilla. In maxilla, lesion is usually seen anterior to the first molar, whereas in mandible, lesion is mostly seen posterior to the first molar. It is usually asymptomatic and may be associated with the unerupted tooth. Now, radiographically, if the lesion is smaller, you will see a well-defined unilocular radiolucency. If the lesion is antilocular lesion. Now, lesions are in the periradicular area, which may cause root resorption. You can see यहाँ पर थर्ड मोलर के पास है मैंडिबल में और ये प्रॉपर एक रेडियोल्यूसेंट एरिया. Now histologically it is similar to your COF. Now what is simple cyst? There is a tumor mass which is composed of mature collagen fibers with ciliate fibroblasts in a whorl pattern. You can see small islands or nests of the inactive odontogenic epithelium. You can see in this picture. यहाँ पे simple form में present. WHO type में क्या है? It is composed of mature, fairly cellular fibrous connective tissue with collagen fibers which are arranged in interlacing bundles. It shows long. Now it will show calcification, which is composed of cementum-like material, that is dentin. As you can see, ये dentin यहाँ पे पूरा cementum-like material यहाँ पे present है. The next is the odontogenic myxomas. Now, these are the tumors which arise from the mesenchymal portion of the tooth germ. Clinically, it can be seen between the second and third decade of life, rarely before the age of 10 years or after the 50 years. Again, it has male predilection. Mandible is more commonly affected than the maxilla, and it is usually asymptomatic. It's a rare lesion which expands the bone and may cause destruction of the cortex. Now, radiologically, it's a unilocular or multilocular radiolucent lesion. It may have a mottled appearance. It may cause displacement or resorption of teeth. The radiolucent area may contain thin, wispy tubercular residual bones arranged at the right angle to one another. As you can see, ये पूरा tubercular यहाँ पे involve कर रहा है. ये इसका gross specimen है. Now, histologically, you will see loosely arranged spindle-shaped and stellate cells with long fibrillar process, myxoid intracellular fibers, and the ground substance contains 2-acid mucopolysaccharides. You can see in this picture, ये इसका low power में है, जिसमें हमने एक section of mandible लेके दिखाया. Now this is the high power view which shows typical. देखो कैसे यहाँ पे एकदम loose myxomatic stroma है, इसमें आपका slender process है जो extend कर रहा है from the mesenchymal cells. अब हमने इसे स्टेन से यूज किया, दैट इज एल्शियन ब्लू स्टेन हमने यूज किया जिससे कि यहाँ पे ग्लाइकोसेमिनोग्लाइकेंस शो करता है. तो अगेन इट्स एन इंपॉर्टेंट क्वेश्चन कि इसमें आपका कौन सा स्ट्रेन यूज हुआ. The tumor cells they exhibit high alkaline phosphatase and lactate dehydrogenase activity. Ultrastructural studies show two types of cells. First one is the pale cell that which represents secretory cells, that is synthesis of mucopolysaccharide. Second are your dark cells which contain crystallized collagen fibrils. The treatment includes a curettage and there is a risk of malignant transformation to myxosarcomas. So this was all about the odontogenic tumors. So this topic now completes both your odontogenic cyst and odontogenic tumors.